Hello, all. So for the sake of time, as you know, Andrea Rowan from WUSA 9 will serve as our moderator today. For the sake of time, I would like to thank you all for joining today's webinar. We will be addressing the impact of viruses and related cancers on minority populations. We have three panelists that I know that you will very much enjoy, who has great insight into what we're all trying to accomplish, which is really to prevent cancer. So without further ado, I would actually like to turn it over to Dr. Sherry Wallington.
Oh, thank you, Kanisha, so much. And today we're going to be talking about HPV. Let's see, my slides are not working. Oh, great. Okay. Ooh, hold on one second. So today my topic focuses on HPV-associated cancer disparities. And the polling question for today is, what types of cancer are attributed to high-risk HPV? So I'm going to give you an opportunity to answer those questions. So our poll is now in progress. What types of cancer are attributed to high-risk HPV infection? HPV standing for human papillomavirus. Oh, great. Okay, so our results are in. 8% said cervical, vaginal, and vulval cancers. 0 said anal cancers. 0 for oral pharyngeal cancer. 0 for penile cancers. And then 92% said all of above. Okay, well, we certainly are going to move forward with our presentation today. And now that the poll is over, let's see if I can get to the slides. Okay, so HPV background. HPV is the most common sexually transmitted infection in the U.S. There are about 40 types that favor infection of the anal genital epithelium. 12 types are considered cancer-causing, and the types are 16 and 18 for most cancers. Typical infection clears in 6 to 24 months. Persistent infection associated with malignancy. And these HPV types can also infect the mouth and the throat. Okay. The next slide shows the number of U.S. cancers and genital warts attributed to HPV infections. And this slide is from the President's Cancer Panel, and certainly we see the number of genital warts in males and females. And then as we move up the pyramid, we see certainly cervical cancer. But beyond cervical cancer, as we asked in the poll question, we see cancer of the oropharynx, the anus, the vulva, and then juvenile onset recurrent respiratory papillomatosis, which are tumors that grow in the respiratory tract, and then also vagina cancer and penile cancer. Now, we do have 3 FDA-approved HPV vaccines, as you can see on this next slide, for both girls and boys. Cervarix is only approved for females, and then Gardasil, girls and boys, and now Gardasil 9. Now, the previous recommendation was that girls for Gardasil and Gardasil 9 receive 3 doses of the vaccine, and also for Cervarix. And you can see that these vaccines cover different types. But now there has been a policy change, and so now as of October 12, 2016, the Food and Drug Administration has now approved a 2-dose schedule for Merck's Gardasil 9 for males and females. And so for teens and young adults who start the series later at the age of 15 through 26 years, they will continue to need 3 doses of the vaccine. Okay. And when we look at HPV, we can also want to be sure to note that disparities can be seen by knowledge, race, ethnicity, and also geography, insurance, and vaccine uptake and completion. The next slide shows HPV-associated cancers, where you see among females, Blacks and Hispanics have some of the highest rates. Okay, and then one of the things we asked in the poll, when we look at oropharyngeal cancer, these are oral cancers by race, ethnicity, and sex. We also see disparities, again, by race, with white men having some of the highest incidence of oral cancers as well. And then we also see disparities in communities of color. Black men have higher rates of anal cancers than white men. Hispanic men have higher rates of penile cancer than non-Hispanic men. Black, Hispanic, and Asian and Pacific Islander women are often diagnosed with cervical cancer at a later stage than white women. And then Hispanic women have some of the highest rates of getting cervical cancer, and Black women have the highest rates of dying of cervical cancer, as well as Black women also have the higher rates of vaginal cancer. So see, these are some of the common disparities that we see in communities of color. And certainly when we look at HPV vaccine policies, mandates, education, and funding, we also see that this varies by state. The District of Columbia, where I'm located, we passed HPV legislation. Also Virginia, as well as Rhode Island. And estimated coverage at the state level, we can see by these coverage maps. Among females, we see low uptake in states like Kansas, Missouri, Tennessee, Alabama, and Alaska. But we see higher uptakes, greater than 70%, in Washington, D.C., North Carolina, New Hampshire, and Rhode Island. And then we see similar patterns among males. And some of the reason for some of these coverage differences and uptake differences, when we look at some of the top 5 parent reasons for not vaccinating girls, I think it's important to remember the number one predictor of HPV uptake is certainly a provider recommendation. So you see in this slide that not recommended is one of the top reasons for not vaccinated, and a lot of the literature shows that parents are stating that their physicians are not, providers are not recommending the HPV vaccine. Also, other reasons relate to not sexually active, safety concerns, not needed, and also lack of knowledge. So what do we need to do to accelerate HPV vaccination? From a policy standpoint, we need to advocate for, including Medicaid, to cover HPV vaccinations, advocate for healthcare payers to adequately reimburse healthcare providers who make the vaccine available. And also, some research has shown funding the development of school curricula on HPV vaccination. And then among our providers, providers need to treat HPV vaccination as a routine vaccination, bundle it with other recommended vaccinations, use culturally appropriate communication strategies to educate patients and parents, and then strengthen the use of the electronic medical records to identify eligible patients, and also use the medical record to send out reminders. And so the most important thing is to remember that many organizations around the country, such as the National Cancer Institute, have released consensus statements supporting HPV vaccination, as well as other national organizations and advocacy groups. And the most important thing to remember is that HPV vaccination is cancer prevention. Thank you so much.
Dr. Sherry Wallington, thank you. My name is Andrea Roan. Just sorry, had some technical difficulties joining you in this webinar, but I'm pleased to join you now, and it's my pleasure now to introduce Dr. Sherry Cohen. Dr. Cohen is the Director of Public Health for the Hepatitis B Foundation, and for the past 17 years, she has planned, implemented, and evaluated community programs and research projects focusing on hepatitis B and liver cancer. Dr. Cohen is co-founder and director of Hep B United Philadelphia, a coalition and campaign to increase testing, vaccination, and linkage to care in Asian and Pacific Islander communities. Nationally, she is chair of the Coalition Against Hepatitis for People of African Origin. Today, Dr. Cohen will discuss hepatitis B and its effect on the Asian, African, and Pacific Islander populations in the United States. Please join me in welcoming Dr. Sherry Cohen. Dr. Cohen?
Thank you, Andrea. Thanks for having me. Okay, so the polling question we have now is, it's a true-false, and the statement is hepatitis B is the #1 cause of liver cancer globally. So we're going to give you all about 5 to 10 seconds to take the poll, and then we'll read off the results. I will just read it one more time. Hepatitis B is the #1 cause of liver cancer globally. True or false? Wow, well done. So it looks like 86% answered true, and that is correct. Hepatitis B virus is the #1 cause of primary liver cancer or hepatocellular carcinoma globally. And with that, we are going to go into more interesting facts about hepatitis B and liver cancer. Hepatitis B is the most common serious liver infection in the world caused by the hepatitis B virus, and the virus can cause both acute and chronic or lifelong infection. And worldwide, hepatitis B virus causes 240 million chronic infections. And in the US, there are about 2 million Americans chronically infected with hepatitis B. Hepatitis B is most commonly transmitted around the world from mother to child during the childbirth process, but it can also be transmitted in these other ways. Anytime you have direct blood-to-blood contact with infected blood or infected bodily fluids, you can have transmission of hepatitis B. The good news is there's a safe and effective vaccine. However, you can see that even with a vaccine that's been in use since the 90s, we still have about 1 million new hepatitis B infections annually. What this means is that we need more infrastructure to improve vaccine rates globally and in the United States as well. The reason we care about Hep B so much and the reason hepatitis B is such an important virus is because of what it leads to. Hepatitis B causes up to 700,000 deaths each year, making it the 10th leading cause of death worldwide. And deaths are primarily due to cirrhosis, primary liver cancer, or liver failure. And we're going to be talking today about primary liver cancer or hepatocellular carcinoma or HCC. Hepatitis B is the #1 cause of liver cancer, of primary liver cancer worldwide, and primary liver cancer is the 2nd deadliest cancer in the world. Up to 25% of people who have chronic hepatitis B will die prematurely from some type of liver disease or liver cancer. What that means is in the United States, that's 500,000 people dying prematurely. And in the world, it's 6 million people, and those numbers continue to grow. It's alarming in the United States that rates of primary liver cancer are going up both in both incidence and mortality. In fact, primary liver cancer is the only cancer in the US that continues to grow in both incidence and mortality every single year for both men and women. And this is primarily due to viral hepatitis B and C. And if you look at the incidence, the number of cases that I have up here in 2012, you can see in 2012, in the US, there were 28,000 cases and about 23,000 deaths. And you notice those numbers are almost exactly the same. And that's because primary liver cancer has a very, very low survival rate. And the 5-year survival rate is only about 16%. The average life expectancy at the time of diagnosis is about 4 to 6 months. And that's due to the late stage of diagnosis that typically occurs and also to the lack of effective treatments. The good news is that diagnosing someone with Hep B and therapy reduces liver cancer, and giving them appropriate therapy reduces liver cancer risk by 50 to 80%. So we know what we have to do. We have to get people diagnosed and into care. Hepatitis B is also related to a number of different health disparities. You can see here that chronic Hep B and liver cancer represent the #1 health disparities for Asian Americans and Pacific Islanders in the U.S. And they take about 50% of the infection burden in the United States. And the liver cancer rates among Asian Americans and Pacific Islanders are between 2 and 13 times higher compared to other ethnic groups. It's also important to mention that there are significant disparities associated with Hep B and liver cancer among African immigrant communities as well. And community studies around the U.S. are showing very, very high prevalence rates of between 5 and 15% in African immigrant communities. And we know that primary liver cancer tends to affect African immigrant men at very young ages. And so that's an area that we're going to need to continue to prioritize in terms of research and care. Looking at this is the care cascade, or the hepatitis B gradient from infection to care, and you can see the great slope there between the number of infections we have in the U.S. and the number of people who are screened, and then the number of people who are able to enter care, and then finally the number of people who are prescribed treatment for their hepatitis B. And the big picture here is that less than 25% of Americans are diagnosed with Hep B, which means 75% of people who have Hep B don't know they have it. And that less than 10% of Americans are being treated. So even when people know they have Hep B, they're often not able to stay in sustainable care, and they're not able to access medication. So what's going on here? Well, it's pretty complicated. Hepatitis B is a silent infection. There are a number of barriers to screening for communities that are most impacted. Highly impacted communities tend to be hard to reach. They have potential limited English proficiency. They're underinsured. They often have many cultural barriers to healthcare access, as well as systemic barriers. And remember, there's very low knowledge level about Hep B among the community and among providers. So you wind up with a situation where community members who are high risk don't ask to get tested or don't have access to a doctor to test them. And then primary care providers who are seeing these communities often don't know that they should be testing their patients for Hep B because they're not necessarily sure who's at risk, or they're not sure how to test. So you have a double whammy. And then when you add the fact that Hep B is a stigmatized disease, and that's just on top of everything else, often people don't want to know if they have it. So you can see why hepatitis B testing is so low. But one of the major keys to addressing liver cancer in the U.S. and in the world really is to improve diagnosis of Hep B. We can prevent a large proportion of liver cancer if we can prevent, diagnose, and manage hepatitis B in the U.S. So by using the hepatitis B vaccine, we can prevent the next generation from getting liver cancer. If we get infected individuals diagnosed, if we can get infected individuals diagnosed and then get them into appropriate care and treatment, we can prevent them from developing liver cancer, because the antivirals that people are treated with can be very good at preventing liver cancer from developing. And then if you have early detection of liver cancer through screening methods, once people are in care, they can detect liver cancer early enough so that it is potentially treatable and curable. So you can see that there are many steps to preventing liver cancer or treating liver cancer. However, there are barriers every step of the way. So I want to talk about these gaps in a little bit more detail. In terms of prevention of hepatitis B, where are the gaps? Well, we know that all babies in the United States are supposed to be vaccinated for hepatitis B starting at birth. However, we have much lower than optimal birth dose rates across the United States. And this includes the problem of perinatal mother-to-child transmission. It's estimated that there's about 25,000 women in each year in the U.S. who give birth who are infected, and their babies are at high risk for infection themselves. We have the tools to prevent these infections, but even with the tools that we have, there are still about 1,000 perinatal infections in the U.S. each year. So we clearly have a lot of work to do. We also have work to do in terms of adult vaccine coverage rates, which are, right now are very low. We already talked about the fact that we have very low hepatitis B screening rates in the U.S. and that we have limited access to care for most infected individuals in the U.S. What we also have is a situation where people, even once people get into care for hepatitis B, they're not being appropriately screened for liver cancer. Liver cancer and Hep B are often asymptomatic, so even when someone has early stage liver cancer, they may not know it. And while the AASLD has guidelines for screening people who have hepatitis B for liver cancer, these guidelines are not often known or they're not often followed by the provider. And some patients will fall outside of those screening guidelines, and so they will miss some patients anyway. So we have lots of patients who wind up being detected with liver cancer when it's too late. And then in terms of treatment, we just don't have enough treatment. Treatments for advanced liver cancer are lacking. And that a lot of that has to do with the lack of prioritization and the lack of research. There have not been significant improvements in treating liver cancer, and that's a big problem. So what can we do? Well, there's quite a bit we can do, actually, and this circle kind of shows the different steps and how they work together and what we can do to overcome each of those gaps. In terms of education and awareness, well, we worked and can continue to work to make sure that high-risk communities are aware of the risks of hepatitis B, and they're aware that they are at risk. And we can continue and will need to continue to educate providers as well so that they know who the high-risk communities are and are able to screen for hepatitis B and then also manage and screen for liver cancer. We work to improve screening rates for hepatitis B, especially among high-risk communities. And very often around the United States, this means taking screening out of the provider's office and into the community. And there are communities across the country that are providing mass, large-scale hepatitis B testing and linkage to care. And they are significantly increasing and adding to the number of people who are being tested for Hep B. We need to work to improve vaccination, and this means making vaccine more accessible, financially accessible, especially for high-risk, underserved communities, and working through awareness, creating policy change, and making sure that babies are getting the birth dose for hepatitis B vaccines as needed. In terms of care for those infected, we need to make sure that people who have Hep B are in care and that they have treatment. The great news is that there are oral antivirals for hepatitis B that manage the disease and that can prevent progression to liver cancer. We just need to keep working to make sure people can get those medications. And then finally, and this is where we kind of beat the drum, we need to be advocating for more effective liver cancer treatments. We need lots of partnership. We need collaboration between federal, federal, state, nonprofit, and corporate entities have to be working together to make sure that liver cancer is prioritized and that we have the treatments that we need. These are some of the examples of what we're doing in terms of improving awareness among high-risk communities. This is the No Hepatitis B campaign, which is a partnership between the Centers for Disease Control and Prevention Division of Viral Hepatitis and Hep B United Coalition. We do have multilingual and multi-platform awareness, and you can see we have lots of resources that you can use if you go to that website. And if you're interested in learning more, you can also go to hepbunited.org to see what your community might be doing wherever you are in the United States. And then finally, I wanted to leave you with a little bit of information about the Hepatitis B Foundation. We are a national nonprofit organization. Hepatitis B and liver cancer is all we do. We are dedicated to finding a cure and improving the quality of life for those affected by hepatitis B worldwide. And thank you very much. We are so pleased that we were able to participate today.
Dr. Cohen, thank you. Good to hear from you as well. I'm pleased now to introduce Dr. Elmer Huerta, our third and final speaker for the afternoon. Dr. Huerta is the director of the Cancer Preventorium at Washington Cancer Institute, MedStar Washington Hospital Center, a low-cost prevention and screening clinic he founded in 1994 as a vehicle for reaching the underserved urban Hispanic community in the Washington, D.C. area. He is also known to millions of Spanish-speaking people around the globe for his nationally and internationally syndicated radio shows. Dr. Huerta will discuss hepatitis C in the Hispanic community. Dr. Huerta, good afternoon.
Hello, Andrea. Thank you very much, and good afternoon to everyone in this webinar. I will be talking to you about some of these virus-related cancer among Latino Hispanics, and just going to take the poll that we all are taking. Is this true or false? Please respond. Virus-related cancers are more frequent among Hispanic populations. It is true or is false? I'm going to give you some seconds so you can answer to this question. Virus-related cancers are more frequent among Hispanic populations. Let's see. Okay, very good. 90% of all you said that it is true, which is the right answer. As we will see in a little bit, virus-related cancers are much more frequent among the Latino populations, both here in the United States and also in Latin America. This is the first slide that is showing you a comparison between the number of people of the causes of death, the leading causes of death among Latinos and non-Latinos in the U.S. in the year 2002. This is data from the National Center for Health Statistics. You can see a very important difference here. For Latinos or Hispanics, cancer is the number one cause of death. It is not heart disease, which is the number two, as you can see in the slide, which is different for non-Hispanic whites. They have a heart disease as number one and cancer as number two. Okay, that's an important difference. The cancer side, with the high rates among Latinos, the statistics that are recent. The statistics about the cancer incidence and mortality among Latinos are a recent set of data in the United States. You know probably that it was not until 1988 that the death certificates in the United States of America did not register Latinos, the causes of death among Latinos. So it's important to know that all these statistics are kind of recent. What we know now, and this is data from the American Cancer Society, they publish a very important document every year, which is Cancer Facts and Figures for Hispanic Latinos. You can see it. Is that they have very high rates of cancer related to infectious agents. Cancer of the liver, which I saw from Dr. Cohen, how hepatitis B and C causes this. Stomach cancer, which is related to a bacteria, the Helicobacter pylori, and uterine cervix, as we were discussing today, is related to the high-risk strains of HBV. So Latinos in general here in the United States, they have disproportionately high rates of these type of cancers, which are related to infectious agents. And this is the piece of information I told you at the beginning of this talk, which is that 1 in 6 new cancers in Central and South America is due to infectious agents, compared to 1 in 25 in the United States in the general population. In the US, the incidence and mortality rates of cancers that are related to infectious agents are higher among the first generation Hispanic immigrants. It is thought that Latinos who come here to live here in the United States, of course, they come with some of the infectious agents that is common in their home countries, and here they develop the conditions related to those viruses. Now talking about liver and bile duct cancer, which is related to hepatitis B and C, as we said. The cancer incidence of the liver cancer is in the US are about twice as high in Latinos compared to non-Hispanic whites, and 3 times higher in men than in women. Liver cancer is expected to be the second most common cause of cancer death among Latinos in 2015. And the chronic infections with hepatitis B virus and or hepatitis C virus account for the majority of liver cancer cases in developing countries, but is a lower proportion in developed countries. So we just heard from Dr. Cohen how these infections are so common in the world, and this, as we heard, 80% of liver cancers in the whole world are related to these hepatitis B and C viruses. Regarding and the primary prevention of hepatitis B virus, of course, is achieved through vaccination. We just heard if every baby is immunized against hepatitis B virus at the moment of birth, well, maybe in 50 years we will be seeing a huge decrease in the incidence of liver cancer in this country. Regarding cervical cancer, that we already reviewed that at the first talk, the incidence of this type of cancer among Latino women is about 44% higher than non-Hispanic white women, 44% higher. This cervical cancer is caused, we heard, by the persistent infection with any of the high-risk types of HBV, human papillomavirus, and it is known that the number 16 and the number 18, they explain up to 70% of all the cases of cervical cancers. And the primary prevention of this infection is possible now through the immunization against HBV virus. I always like to say that I remember when I was in medical school many years ago, that my professors, they used to dream about someday, they used to tell us when we were medical students, we will have a vaccine against cancer. You know, we medical students, we were, yeah. Well, believe it or not, we have now a vaccine against cancer. If we immunize our babies against hepatitis B, and we immunize all children before they are sexually active to this against the HPV, well, it is the potential to get rid of these conditions for many years to come. But it is sad. All the statistics and all over the world show a couple of things. Number one, that even in developed nations, the uptake of these vaccines is not as high as they should be. There are still misconceptions. There are still many kind of situations in which parents, they do not authorize the vaccination of their kids. And the second thing is that this is also sad. Most of the immunizations against HBV virus are being done in developed countries, when we know that this infection is very common among poor countries, but they are not getting this life-saving vaccine against cancer. So that's something that we really need to think about. Number one, how to make this, the uptake of this immunization much more common here in the United States for everybody. And number two, how to work together to make possible that this kind of immunization goes to poor countries around the world, which are suffering the burden of this condition. And we just heard from the two previous presentations how important is education, public education, patient education in this whole effort of cancer related to viruses. If the patient, as we heard, is not aware that he or she has a hepatitis, chronic hepatitis, he is going to realize, or she is going to realize, that she has a problem when the liver is not working well and they develop cirrhosis. If we are not aware that these kind of viruses are silent and they don't give you symptoms, then we are not going to go for checkups or for pap smears or things like that. That's why I just want to briefly share with you the importance of health education to the public, highlighting the work we are doing here at this hospital, the MedStar Washington Hospital Center in Washington, D.C. And this is called the two sides of a coin in cancer prevention and the importance of public education. Here in Washington, at this hospital, 22 years ago, we started this clinic. It's called the Cancer Preventorium. It's a low-cost cancer prevention early detection clinic, which is directed to Latinos at this hospital. This clinic gets people without symptoms only, and the way we have convinced the people to come to this clinic is through the radio. We have daily radio programs for the last 27 years for these people. So every day of the week, Monday through Friday, they have radio programs stressing the need of prevention and early detection of different conditions. So 85% of patients seen at this cancer prevention clinic, they have no health insurance because they are immigrants, for different reasons. They have no health insurance, but they pay out of pocket to come here and get a conversation about prevention, and they pay out of pocket to have a cancer screening examination. That's one side of the coin. The underserved, the poor, they don't speak the language, they have no health insurance, but they come here paying out of pocket to have a consultation on prevention and early detection. The other side of the coin is something that we just found, is that in our hospital here in Washington, D.C., if I go to the 7th floor of my hospital and look to the south, you know what I see? The capital of the United States, the capital, Congress. So in this hospital located in the heart of Washington, D.C., you can read there, we see 22% of breast cancer cases are stage 3 and 4, which means advanced cancer. And you know what? That is double than the national rate. Nationwide, 10% of cases of cancer are advanced, or the breast cancer of the breast are advanced, 10%. Here, at the nation's capital, at this hospital, 22% of women who are coming, they have advanced breast cancer. And what is really shocking is this piece of information here, that 97% of those women do have health insurance. You see the two sides of the coin, the importance of public education. The first group of people, they come here, they pay out of pocket, and have no health insurance. Why they do that? Because they have understood the value of prevention and early detection. The second group, they have all the facilities. They have the money, they have the insurance, they live around here, they speak the language, they live around the hospital, but they don't come on time and they come late. So this slide is just to show you that in all this conversation that we are having today about the importance of detecting early viral infections, preventing all these cancers that are related to viruses, the public education component is very, very important. And this is just to finish this. This is on the left are the Latinos who come to this clinic. On the right, there are African American women living in the district number 5 of Washington, D.C., which are the patients who are coming late. They have some common characteristics, like some of them are poor, of course, more Latinos are poor. Both groups, they have fear to get checked because sometimes people don't like to be checked because they think that they may find something that they don't like. Both are fatalistics. But what is different between these two groups is the culture, of course, the language, the immigration status, the health insurance coverage. I already told you that this group, Latinos, they have no health insurance coming to this clinic. 97% of these people here, the African American population, they come with advanced conditions. But what is really different between these two groups is that this group of Latinos, they have 27 years exposure to a daily media-based health education. So in this whole conversation, my presentation also has the objective of stressing the importance of public education. And I'm finishing with this just as a message to all of us who are scientists. That is the ivory tower of science in which we are. with scientists. You know, there are over 200 people now in this webinar. All of us are scientists. We are in the ivory tower of science. That's a scientist, you know. That's what we're doing right now using electronics. We are talking science. And what we do is that we write reports in our tower, in the ivory tower of science. We write books, we write papers, we write guidelines. We just heard all the guidelines we have for hepatitis B screening or treatment, for hepatitis C or HPV, etc. But sometimes we scientists in the ivory tower of science, we don't realize that we are above the clouds and we are isolated from this family. And this woman right here, she's gonna go with cervical cancer in spite of the guidelines for cervical cancer. Early detection are here, or the immunization are here. And maybe this man right here is gonna come with cancer in the colon, even though right here we have all the signs regarding early detection and prevention of colorectal cancer. So the idea is to make possible, make sure that all this wealth of information that we have now goes to people, real people, in a language that they can understand, and the language that is able to produce on them a positive. So thank you very much for the opportunity to talk to you again on all this issue of viral infections related to cancer. Public education is important, prevention is important, early detection is important, and in that regard, I think all of us, we have a role to fulfill. Thank you very much.
Dr. Huerta, thank you as well very much. To all of those participants on the webinar, you've heard a lot about and learned a lot about HPV, hepatitis B, hepatitis C, and the cancers they cause. We still want to hear from you. What questions do you have for our presenters? And you have some time left before our webinar ends to type in your questions to the question pane of the control panel, and we'll get them to our presenters. But as you're typing your questions, I'd like to talk with our presenters again about misconceptions. Dr. Huerta, you mentioned that, and all of the doctors mentioned the importance of getting this information out, especially in regards to HPV when people are young. But it seems as if, Dr. Huerta and Dr. Wallington, I'll ask you this, we need the medical community to be more involved, to get doctors to help parents think about this in terms of health, getting the HPV vaccine, rather than in a context where parents are worried about promiscuity. How do we change that? What are the guidelines that doctors need to follow to let parents know this is a health issue, the HPV vaccine, not something dealing with sexual activity? Dr. Wallington, I'll start with you.
Oh, thank you so much, Andrea. I think that we're seeing a lot of national and local efforts to help doctors better frame HPV vaccination in the context of cancer prevention. And as I mentioned earlier, to offer HPV vaccination in the same manner they do other approved childhood vaccinations such as Tdap and MMR. And so I think framing it definitely in a cancer prevention context really helps parents understand that what they are doing today to vaccinate their son or daughter may help them prevent cancer, you know, in the future. And a lot of research, one of the literature does show that parents' concerns about if their child does receive this vaccine, does it make them more promiscuous? And a lot of the research shows that it does not impact, you know, decision making. And in some instances, young adolescent girls reported that learning more about HPV vaccination made them want to delay sexual activity. So I think many efforts are being done to help doctors understand, because they have a very difficult job if you just talk to providers, as Dr. Huerta knows, and so they have a lot on their plate, and helping them, giving them the tools they need through better use of the electronic medical record, medical education training around HPV vaccination and how to best communicate it. Those are some of the things I think that are being done and providers find helpful.
Dr. Huerta, would you like to add to that?
Sure, yeah. I think one thing we have to do is try to talk to parents and show them evidence, science-based. And there is a paper that I'm going to pass now to the organizers of the webinar, was published in December the 8th of 2014 in the Canadian Medical Association Journal, and they show very clearly that there is no relationship between vaccination, immunizations, and promiscuity among little girls. So if we somehow prepare little pamphlets or something showing parents science, evidence about that lack of relationship, maybe some parents are going to consider, doing the immunization for their kids. So I think we need to be much more proactive in trying to use what we have been published to give it to the parents.
Dr. Wallington, we have a question from one of our participants listening to the webinar. Why do Black women die more of cervical cancer than other racial groups, even though they don't have more cases?
I would say it has a lot to do with, as Dr. Huerta so eloquently said, about education, and then also access. And certainly we have seen the impact of lack of insurance, and as Dr. Huerta also mentioned, fatalism, where people have a fear of going to see a medical provider because they are afraid that they're going to find something. And we see this not only with cervical cancer, but other types of cancer, such as colon cancer and also breast cancer. But I think the key is to not only educate African American women, but all women about the importance of getting Pap screening. The Pap screening guidelines have changed, whereas the recommendation was that women would receive Pap screening every year. Now it's every 3 years, and I do think there's some confusion now regarding that. And so educating all women, about the screening guidelines, the need to have a medical home, that there are programs such as the state breast and cervical programs that provide low-cost screening, make screening available for free to women who cannot afford it, not just cervical cancer screening, but mammography screening. So I think it's lack of education, lack of access, and then sometimes it's just logistical things like transportation, to get to a medical home. And so these are things that we need to get the message out that there are programs available that can help with that.
And that leads to a question that we just had. You basically answered from one of our webinar listeners about making HPV vaccine more equitable to African American communities. We are getting to a point in our webinar where we do have to wrap things up. I do want to thank our participants, Dr. Sherry Wallington, Dr. Shari Cohen, and Dr. Elma Huerta for being with us for this very informative hour learning about HPV, hepatitis B, hepatitis C, and misconceptions that are probably preventing people from getting the vaccines they need to save their life. Thank you for clearing through some of that. Thank all of you for your attention today on the very important issue of preventing virally induced cancers. Now, if you have any other questions, please contact Gabrielle Taylor at Gabrielle, Gabrelle.Taylor at preventcancer.org. Now, once you leave today's webinar, you will receive a survey on the presentation, and we would appreciate it if you would complete that and provide your feedback. You will also receive a follow-up email within 24 to 48 hours with a link to view a recording of today's webinar. It has been an honor to serve as your moderator today. I hope that you've been inspired to take this message to the public and to reduce the prevalence of these viruses through vaccination, screening, and treatment to stop cancer before it starts. On behalf of the Prevent Cancer Foundation and our presenters, Dr. Wallington, Dr. Cohen, and Dr. Huerta, thank you for joining us today and have a great rest of your day.
Thank you.
Thank you.
Thank you.
You're welcome. Good talking with all of you again.